Knowledge is not enough. A case study review by Charles Johnson, me, Managing Systems Change and Improving Patient Outcomes as the class, and Professor Marissa Tierney is a professor, and I'm at the RN BSN program at United States University. Knowing is not enough. Now, this case, I'll take it directly here. On January 10th, a 57-year-old man underwent a liver donation procedure that successfully resected approximately 60% of the right lobe of his liver in preparation for transplanting that liver into his brother, a 54-year-old man who suffered from degenerative liver disease. Now, after what was described as a technically uneventful transplant, the donor patient seemed to do well on the first post-operative day. Late on the second post-operative day, he began to manifest some tachycardia. Early on the third post-operative day, he began to hiccup and complain of being nauseated. He was given symptomatic treatment. Later that day, he vomited brownish material. He began oxygen desaturated and was placed on 100% oxygen by mask. He continued to vomit, aspirated, and suffered cardiac arrest from which he did not resuscitate, and he was pronounced dead on the third postoperative day. Now, what happened? 3 months later, a health commissioner walks in the building and did a 10-page report on an inquiry into the circumstances surrounding the patient's death, offering the following reconstruction of the sequence of events. January 10th, the first post-operative day, patient undergoes surgery to remove the right lobe of his liver. No complications occurs during the procedure. Second post-operative day, January 11th, patient is recovering. His condition is stable. Then, January 12th, patient is examined during the rounds by the first transplant fellow and PGY4 surgical resident. Transplant fellow neither looks at nor asks for the patient's vital signs. At 4 p.m., patient develops tachycardia. January 13th, approximately 1 a.m. in the morning, developing hiccups and nausea. Patient is given medication, probably given Zofran or something like that, that masks the symptoms of the nausea, which wasn't the underlying problem. You have a patient with abdominal surgery, and you're not thinking, oh, hiccups, phrenic nerve, vagus nerve. The first thing you should have been thinking about. And then you let a patient go at 4 p.m. Within 48 hours of surgery, what tachycardia, and never got a telemonitor, never looked at the blood pressure to see if this is possible bleeding out. So at 8:45, patient examined by a PGY4 surgical resident who is unaware of the patient's continuing tachycardia and nausea, previous hiccups, and writes a progress note indicating that vital signs are stable. And the nurse sees all this and has it advocated at this point. Nobody's advocated from 4 p.m. the following day till 1 a.m. He never went to a supervisor. He never went to anybody. 1 p.m. patient vomits brown materials. Obviously, he was bleeding, and the transplant fellow was at a bookstore outside the hospital and had to be paged. And he says, you didn't even look at the patient, but don't insert a nasogastric tube. Upon returning to the hospital, and despite the patient's distress, he does not examine the patient, but instead prepares a preoperative workup on another patient scheduled for surgery the next day. So he don't take interest. Nobody's moving in the right direction here. Nurses are advocates. 2 p.m., patient oxygen saturation is unacceptable, low. 100% oxygen is given. 3 p.m., nurse calls PGY1 resident to inform her that the patient is continuing to vomit and has difficulty breathing. 3:10, patient is unconscious after vomiting more brown material and frank blood. Code is called. Resuscitation is unsuccessful. 3:40, patient is pronounced deceased. And this is taken directly from knowing it's not enough, case study. Uh, what went wrong? Well, the first thing that went wrong that stood out to any prudent nurse is that the first year transplant fellow and PGY4 surgical resident, they neither look at nor look at any vital signs. And then the nurse also knows patient developed at 4 p.m. about 48 hours or not less than 48 hours after getting out of surgery develops tachycardia. Okay, I might I might look at tachycardia and go, okay, can I give a beta blocker? But if I look at the blood pressure and I see a low blood pressure or the blood pressure is getting low, I know that it is not a heart problem. It's not a blood pressure problem. It might be possible bleeding. And I think post-op bleeding, I think first thing is what I'm thinking. First off, the case study states approximately 1 a.m. patient develops hiccups, nausea. Patient is given medication to control the symptoms, probably Zofran, like I said. However, if I'm thinking abdominal surgery, I should be thinking about the phrenic nerve, should be thinking about the vagus nerve, should be something's wrong, something's not right. Patient could be bleeding. There might be time to examine the patient. And at 4 p.m., I would have been telling my coworker. They would have went to the resource nurse for me. If I would have told anyone, they would have called the doctor, a house supervisor, a house doc, got the patient a KUB, anything. But how can the issues have been resolved? So nurses are advocates, and as advocates, the nurse should have went into action because the title says knowing is not enough. The nurse could have told a senior nurse or a coworker with more experience. If I would have told anybody, if somebody would have told me that, I would say, yo, man, you need to go and talk to the resource nurse, supervisor, another doctor, house doctor, anyone. We need to get eyes on this patient. We dig in the abdominal, we get a KUB, see it bleeding. We check to see the other vital signs. Anything, but nothing was done. The nurse chef, like I said, went to the chain of command and it spoke to some supervisors, management regarding the patient's condition, but nothing happened. Who and what role do other disciplines have in resolving this issue? Well, anybody in the disciplinary team could have helped with this patient. The respiratory therapist probably would say, hey, let's get an EKG, let's get a telemonitor on this patient. We could have did that. We could have got a cardiac monitor on the patient, house supervisors, physicians, case managers, another nurses. Anybody could have helped with this patient. And it's basically that failure to do so will end in harm, as I stated here in my overview. Now, knowing is not enough. The nurse should monitor their patients and anticipate complications. If complications occur, the nurse should immediately inform the physician of the patient's clinical status. They should document clinical observations in a way that reconstructs the patient's assessment, notification of others, and the timeline of events. The documentation will include conversations with the physician on the patient's condition, name of the physician, and time of notification. Lastly, the nurse should make sure the documentation shows the nurse pursued a resolution. The nurse pursued nothing. Doctors pursued nothing. And this is a problem. Walter Saunders said a trained nurse is required to possess ordinary skills and knowledge and exercise ordinary care and diligence under all conditions, and when required to use her own judgment, must use her best judgment. Now, the nurse didn't use any judgment, and I'm approaching this as a nurse because I'm a nurse, but a lot of people messed up. We know the physician messed up. The physicians dropped the ball, but the nurse should have went to somebody. They should have advocated, and that's the main thing. Nurses have to be taught to advocate. Educate nurses on appropriate behavior and when physicians do not respond as needed. If I don't hear back from a physician, I call and it's an emergency. Typically, I'm going to get some other eyes on that patient, house doctor, anybody. Call cold, rapid response. Rapid response could have been called at 1 a.m. If the patient's declining, hiccups, rapid, get all eyes on this patient. Nobody called anyone, and it was over. It was just way too long for this for a nurse, and we probably had 3 or 4 nurses in this span of time, and if they were reading the chart notes, they would have saw that this was going on for a while. Have annual training. Nurses need education. Everyone needed education on this, including the doctors. Have approachable nurses and supervisors. So the supervisors should have been notified. Maybe they were scared. Maybe they thought they were doing something wrong. Maybe they wanted to listen to the doctor, but you got to advocate for your patient. Encourage additional schooling and certifications. They would have known. Have less experienced trained nurses. Work with more experienced trained nurses. And monitor acuity and properly assign patients based on their skill level. I always know when I was an LVN, I didn't take certain patients with heparin drips and stuff like that because I knew that I probably wouldn't be able to handle it as well as an RN. Now that I'm an RN, I got the knowledge to handle it better and look at the therapeutic levels. However, knowledge could be a barrier, so proactive nurses will maintain competency through continued education and certifications. Communication could be a barrier. You got poor communication here. They're not communicating what's happening, what they're seeing to the doctor, or the doctor's not listening. The doctor's not getting the what's happening. The nurse is not conveying it. The doctor's not getting it. Something is happening here that we must go ahead and we got to let the nurses know that they can't be afraid of conflict with physicians, especially when they're advocating. Nurses need to know that they may not be able to depend on the physician's judgment all the time. The nurses are health professionals. They can make decisions. They could call codes if the doctor get mad at something like this because you called a rapid response. Maybe he was still breathing, but you could have called a rapid response because he definitely was declining. People may not be ready for the change. That's one of the number one barriers. That and communication. Communication is number one. I would say people not being ready for the change would be number 2. You have to train people. People have to. So this is again the case study by Paul Baltodin. Knowing is not enough. Retrieved there in my class at United States University. And these are some of the references I used. And I would tell anyone, if you're met with something like this, you have to advocate for your patient. I approached this from a nursing point of view, and I felt like that was more appropriate for this case study because I'm a nurse, and I think that anyone that would be in this situation must at 4 p.m. they should have did something. Shouldn't have waited till 1 a.m. The next nurse on duty might be more seasoned. You're telling me all these seasoned nurses didn't see anything, didn't see it was time to go ahead and say something? Somebody should have did something at some point and got a doctor. And if you couldn't get a doctor, you get somebody else. You get a supervisor. You go to chain of command. They should have got eyes on at 4 p.m., especially with a patient that is 48 or less than 48 hours out of the post-op. So I thank you for your time. Thank you for listening. I hope you enjoyed what I had to say, and have a wonderful day. Thank you.